unable to join us for today. So we did want to note that this meeting is being recorded. If you do not consent to being recorded, we do ask that you drop off at this time. Thank you. Okay, welcome everybody to the first webinar in our series, Exploring Tribal Public Health Infrastructure and Capacity. This first webinar will focus on tribal public health workforce. My name is Nina Martin. I'm a program manager at the National Indian Health Board and work on a number of our projects across infrastructure and capacity. So very excited to be here with you today. Just a quick overview of today's webinar. We'll go a little bit into some of the background of tribal public health infrastructure and workforce, and share a little bit more information that we have on tribal public health workforce from the Public Health in Indian Country Capacity Scan. As well, we'll talk a little bit and engage in an open discussion session towards the end about planning for the future and really understanding the needs and efforts to strengthen the tribal public health workforce. As always, if you have any questions, please feel free to put anything in the chat and I'll monitor that periodically, and we'll also have time at the end of the conversation for discussion. For those of you who are unfamiliar with the National Indian Health Board, we are a nonprofit celebrating our 50th birthday this year, which is very exciting, established by tribes to advocate for federally recognized American Indian and Alaska Native tribes. You'll see some of our team probably periodically throughout meetings, other webinars as well, including myself and Carrie Joseph, our deputy director, and a number of our public health staff who work to make PHICCS possible. So if you see any of us anywhere or at a conference or meeting, please come say hi. So just a quick thing before we jump into the webinar. We want to know where folks are dialing in from. And to do this, it's just a fun little exercise. If you hover over the top menu of your screen, you should see an Annotate feature. There should be a button that if you click on that allows you to put a stamp somewhere. And then you can just put a stamp over where you're dialing in from today. Okay, I see some folks all over the place: Oklahoma, Arizona, Oregon, Washington, DC, Alaska. Wonderful. We're glad to have you all here today. Michigan, Montana. Excellent. We're so excited you all can join us. Let me just clear that for a second so it doesn't. Oops. Okay. So moving on, we'll talk a little bit about tribal public health infrastructure, some of the base pieces around tribal public health workforce. And really, when we talk about tribal public health, we're talking about the inherent right that tribes have to protect and promote their people, the health and welfare of their citizens, using methods that are most relevant for their communities. We're talking about public health systems that are managed by tribes and that serve tribes. We also understand that tribal public health systems can look different perhaps than state and local or even federal public health systems, and can be highly varied across tribes and organizations. Another term that we commonly see when talking about tribal public health is community health, again, really reflecting the provision of health across for all. We wanted to note some key players in tribal public health, of course, the tribe centered there, and that is kind of the base for public health systems and services, but also other entities and organizations that can provide or contribute to the public health system of a tribe, including but not limited to federal government, such as services that may be provided by the Indian Health Service, national and regional organizations such as area Indian health boards, state and local health departments, private nonprofits, and urban Indian health programs. All of these entities may in some way or some combination interact or provide public health services. We also want to go over a little bit about what we mean when we talk about community infrastructure versus public health infrastructure. That's kind of the base for our series. And when we hear community infrastructure, how we use it is really talking about kind of the base structures, organizations, facilities needed for the operation of society. So kind of the base things that you need, including transportation, communication networks, sewage, water, and power. For me, I tend to think of these as kind of the built environment, things that I interact with. And when we talk about public health infrastructure, similar but slightly different in terms of referring to the physical and organizational structures and facilities needed for a public health system. So really all of the facets that you need to ensure that the community and people as a whole can be healthy and have the conditions to do so. So some of these may be similar, such as communication networks, access to broadband, but also include specialized components such as the public health workforce, public health authority, and means and mechanisms to enforce that public health authority, and partnerships, including partnerships that a tribe may use to provide services and build their public health systems. Talking about, why focus on tribal public health workforce needs specifically for this issue brief, and as one of the three that we're highlighting over this series. We know that workforce is one of the backbones of public health service delivery. We know that tribes have been calling for years for the need for skilled health and public health workforce investments and capacity. And particularly over the last 2 years during the COVID-19 pandemic, we've seen significant investments in public health infrastructure broadly, as well as specifically in workforce through the American Rescue Plan and other bills. We know that this is going to be an issue for public health as a whole over the coming years, and it's imperative that we understand tribes' workforce needs to ensure that tribal public health systems are included in these conversations. However, there's little info that we do know about national level estimates for tribal public health workforce. We know that there are clinical estimates for healthcare workers that are maintained by HRSA and NIHS, but to our knowledge, no such equivalent for public health positions specific to the tribal public health workforce exists. We do have some data, recent data as of late 2021, estimating the needs for local and state health departments, specifically local non-tribal health departments that serve under 100,000 individuals, have some of the highest public health workforce needs. Breaking this down, we know that there's data for local health departments under 25,000 individuals needing the highest increase at about 230% full-time equivalents increase to perform the basic public health functions. So we know there's data for state and local. What do we know for data related to tribal public health workforce specifically? One source of information that we have is PHICCS, information for tribal public health broadly. What is PHICCS? You may have attended an NIHB presentation before on PHICCS during the launch or during the release of the 2019 report. PHICCS stands for the Public Health in Indian Country Capacity Scan, which is a national scan to be conducted every 3 years by NIHB. The purpose of this scan is to assess the capacity, infrastructure, and needs and priorities for tribal public health. It's informed by tribes and is a national level scope. PHICCS is very important to ensure that tribes, tribal organizations, partners, and policymakers better understand the needs for tribal public health infrastructure and to plan for the future and for future improvements. This is just a slide highlighting the PHICCS 2019 report, which is currently available on NIHB's PHICCS website. You can read all about the first capacity scan that was conducted between 2015 and culminating in the report launched in 2020, and is really meant to provide kind of the first baseline information and estimates to support and guide essential public health work in Indian country, and provides the first initial pieces of information to strengthen efforts to educate all partners involved for building capacity for tribal public health. Let's check the chat 1 second. Thank you, Carrie, for sharing that. Carrie just shared a link in the chat for access to the report, as well as you can view the scan infographics that we've created for the report, as well as other useful information. So what do we know about tribal public health workforce needs from PHICCS? First off, we love to show this slide because it really emphasizes the amazing work that tribal health organizations do. You can see that they are one of the key providers, actually the largest provider of public health activities, and provide a wide range of services from adult and childhood immunizations to environmental surveillance and regulation, as well as alongside services that other partners, such as other departments within the tribe, health service, other organizations may provide as well. Going further into the report, we know that there is detailed information on both funded and filled positions across a number of different public health positions, as well as vacancies and opportunities to fill those positions. This, if anybody has a copy of the report handy, is on page 54, big table. And we're going to dive into this a little bit. This is just an overview where you can see there are 24 different positions that were assessed during PHICCS. One ranging from operational and agency leadership management to specific positions such as environmental health workers, community health representatives, public health nursing, and others. The hope was that these positions represent the broad range of folks who may be providing or engaged in public health services within a tribe. Going further into this, we can see the total average number of FTEs, for example, for behavioral staff. Of those who responded, we know there's an average of 8.7 FTEs funded, 6.6 filled, and there's a need for 1.8 roughly FTEs additional to perform the behavioral health functions, and this is aggregated across all respondents. We know the same for community health representatives as well, and we can look at epidemiologists and statisticians. For example, compared to behavioral health staff, we can see that the funded FTEs for this are about 0.2, and there's a need for about 0.4 FTEs. So looking at the highest averages of those funded and filled, we can see that a lot of these positions are behavioral health staff leading this position type of highest average funded and filled, followed closely by operational support positions such as leadership, business and financial operations, administrative staff. Many of these positions are critical to supporting the day-to-day function of public health departments and activities. On the flip side, when we looked at the highest averages for funded FTEs that are vacant and additional funded FTEs that are needed, we see again, behavioral health staff are both the highest average number funded and filled and the most needed positions that are currently vacant. We also know that THOs commonly cited a need for frontline workers, such as community health representatives and public health nurses. This is important because in many tribal communities, we know that these professionals serve important roles in delivering public health services and addressing social determinants of health. They also represent an extremely important, unique positions that exist in tribal public health systems. We also asked specifically in PHICCS 1 about needs, priorities, and opportunities for workforce development that respondents would like. We know that THOs noted training, such as training on technical skills, including data collection and analysis, as well as general public health training, certification and licensing for public health, staffing considerations, including strategies for hiring and retention, support related to assessment, performance improvement, and accreditation, as well as technical assistance, specifically again around epidemiology, data analysis, and public health informatics for commonly cited needs. So looking forward, we want to have a discussion with everybody here around building tribal public health capacity, thinking about future needs. Based on NIHB's experiences and what we've heard from tribal leaders, subject matter experts, and in previous conversations, we've identified the following items that may be helpful in supporting tribes as they work to address tribally driven priorities, including those specific to tribal public health workforce. We know that there is a long effort of tribes developing systems to care for the community as a whole, and we feel that it's important that future efforts include a focus on building capacity at a local level within the tribe, local here meaning within the tribe and not necessarily a local health department as a county or city health department. And really investing in local tribal level capacity and retention, in addition to investments in support that may be obtained from other areas, such as tribal epicenters, federal training programs, support that may be accessed through state and local health departments or other entities. Training programs specifically to build public health competencies, including for Native youth and students who may be aspiring to enter public health fields, is extremely important. We know that these programs can help to build the next generation of public health professionals and ensure continuation and support and really build capacity at the tribal level. We've also heard the need, particularly over the last 2 years in our support of tribes during the COVID-19 pandemic, is that future workforce development efforts must recognize tribal sovereignty and really be flexible to allow tribes to dictate how they need to use funding and funding opportunities to fit the current structure of their public health programs and services. We know that tribal public health systems can be unique in that there can be a high level of integration between healthcare and public health systems that may not be observed, for example, in a state or local health department system and healthcare system. We know that tribes should dictate how they want their funding and programs to be structured to reflect how they have currently structured their programs. We also recognize that investments in both public health and the clinical workforce are essential. Again, with different levels of integration, many staff may serve different roles or be called on to perform different halves of the same whole, and both reflect the need to focus on the health of the community. One doesn't exclude the other, and tribes may have unique needs for both sets of the workforce. As well, there's been, as we talked about early on, there's recent investments in federal funding specifically for the public health workforce. And we're interested in hearing how tribes can be included in direct efforts to fit that funding and those opportunities to fit their workforce development needs. So we wanted to move into asking some questions and we have kind of 3 core questions that we wanted to hear from all of our participants on and get a sense of where you're at as folks out in the field, as experts, understanding what are your needs and how are you addressing some of these questions. So we have 3 questions. You are welcome to raise your hand and we can unmute you. You're welcome to pop an answer into the chat box. Also, if you want to go back again to that top bar with the Annotate feature, to the left of the stamp option, there should be an option to add text. You're also welcome to type your response if you want and put that on the screen. So the first question we have for the group is, what tools or resources do you use for your public health workforce development? And these could be perhaps competency assessments or guidelines. These could be professional development programs, pipeline programs. So I see someone's put into the chat the CHES entry-level competency standards. Any other tools or resources that come to mind? We'll see the responses that folks are putting in if they're choosing to use the Annotate feature. It doesn't look at the moment that I see any, but also definitely welcome to put in the chat. or raise your hand if you'd like to unmute and speak. Looking into health equity trainings, CDC Train, ASTDT competencies and competencies for dental directors, the FAB standards and measures, the Public Health Accreditation Board. What tools would you find helpful that maybe don't exist or aren't currently for a tribal public health workforce specific use or audience? Basic Public Health 101 training for tribal leaders to understand the need for tribal public health infrastructure. Oh, yes. Shasta, you should have a prompt to unmute.
Yeah. Hi, thanks. I'm calling in from Denver, and I am just on my lunch break in the car. So if you'll excuse the background, I was going to mention the Public Health Accreditation Board's standards and measures, which was mentioned in the chat. One of the tools that I think would be particularly helpful is to have access to the data from the tribes who have gone through the accreditation process. I think we have 5 right now, but that data is sequestered. And I'm wondering at what point, I contacted PHICCS and said, hey, how can we gain access to this? And they don't have a plan in place yet to release the data. And what the data does is gives us an idea of, is that accreditation giving tribes more access to funding and better able to retain their staff? But if we can't access the data, we're not going to be able to promote that for other tribes. So I think that'd be great if we could have access to that data, but it's not available at this time.
That's a really great point. Thank you for sharing that. I see a lot of comments about data in the chat, specific trainings for public health data analytics, data in general, as was just mentioned. These are really great responses and help us think about what NIHB can do and what we can find more information on to support tribal public health workforce as a whole. Moving on to the next question, and we can come back to any of these as well if folks have questions too that we are not asking that you want answered, or if you want to hear from others who are your peers and participants here, please let us know. We're happy to have that space too. We're interested, kind of the second question that we have is, what are key barriers to tribal public health workforce development? And these can be broad, it can be really just trying to understand what are some of the things that can be improved on to help support tribal public health workforce development, capacity, retention. Funding, recruitment, and housing. Data sharing can be a challenge. What else? I guess the flip side of this question too can be, what are things that really help keep the, increased capacity and development of the tribal public health workforce? What are some things that have helped? Access to internet, relocation, loan repayment programs. Yes, I know I believe there's such an initiative for clinical healthcare workforce and what is available for public health workforce specifically. Reimbursement, having staff to be licensed, licensing and credentialing, education, job-specific trainings. Are there specific areas that folks are finding that having training, technical assistance on key areas of the workforce would be helpful? For example, we know through PHICCS, data and analysis, analytics, epidemiology were cited as important areas for training to support continual development, education, and we can imagine that in the wake of the pandemic, that is an increased need for those types of skills and training. Shortage of professionals. We know, we definitely know the last 2 years as well have really changed the way the public health workforce can be structured, particularly with the move from in-person to virtual and the doors that opens up in terms of location. And we're curious if, just how folks are addressing that. Salary. Retention and promotion of staff. And understanding ways to support staff, particularly those who may be engaged in frontline work. Training specifically on generational historical trauma and the impact on community. Okay. So the last question that we have for everyone is, what has helped grow your tribal public health workforce? Where are your staff receiving training? Where are they going to develop public health skills? And what would you like to see, most importantly? You had $5 million. What would you like to see to be invested to support the growth of the tribal public health workforce? And again, feel free to put this in the chat. You can annotate on the screen. Raise your hand if you'd like to unmute. Yes. Okay. Surely there should be a prompt unmute.
Okay, I got it. So one of the things, one of my colleagues, my name is Shirley Kane, I'm from JBS International, and I'm here because we're working with one of the tribes to help them build a behavioral health center within their tribe. And we've just encountered like so many different issues. But one of the suggestions I was going to make was that they have this awesome process in Alaska called behavioral health aids. And I think that could be something they should consider down in the lower 48 to help. They work directly with therapists, and they have to have training. And then there has to be a state law that it connects to, and then CMS reimburses. But they have to go through a lot of training to get to that place. But I think, it's something that they could consider. And another thing too that Alaska's doing, in another part of Alaska, they're doing trainings on wellness. So they don't need to have the certification, but I don't know about the reimbursement for that. I just wanted to throw that out there.
We appreciate you sharing that. Carrie Dallas, I think you were next. Should be a prompt unmute.
Thank you very much. Working with community, I'm seeing a lot of our Indigenous people who are really lending themselves and connecting internally, heartfelt with that cultural connection to healthcare. And somebody did mention that historical trauma education to health workers. So as an Indigenous person myself, and understanding cultural practices, tribal practices, and being able to bridge that information, that insight into westernized medicine has been very helpful to the programs that we run here. And so I thought that the other thing that I utilize here is we have a university in our urban site that is very close to us. And so they have a huge building where they really serve the population of Native American students. And how often do freshmen go into college saying, I don't know what I want to major in? And it's probably 80% of them. And so if there's that recruitment at institutions, at higher level education institutions that are close to reservations, maybe the tribal colleges, begin. And I mean, we're not just talking about today, we're also talking about our future, right? And so if we're able to get, my grandma always said that the only people that are going to really help us are ourselves. And so I'm really looking, this would be my suggestion. Thank you.
Mm-hmm. I think somebody also put this a similar piece in the chat too, is funding for MPH programs, particularly at tribal colleges. And also I know too, there's been a huge expansion of public health as a study for bachelor's level and beyond. So really, we know folks are interested in this, and there's a whole generation that has this and is being exposed to public health early. So we really appreciate you sharing that. Okay, I think Cole, I see your hand up. You should have a prompt to unmute.
Bonjour, hello everybody. My name's Cole. I'm an enrolled citizen of the Turtle Mountain Band of Chippewa Indians in North Dakota, but live out here as a guest on Coast Salish lands in Seattle. I was just reading through the chat and listening to folks, and I agree with the education piece. I'm currently in a PhD program in Indigenous Health at the University of North Dakota, and I think there needs to be stronger ties to that degree program permeating out into community and working together. Even while we're in school, I think there's lots of opportunities to do some of these public health related projects and data analysis, I think, while we're in school. But I know that we're going to have, cohorts graduating at the PhD level who also would like to go into community and grow the public health workforce. And so I'd really like to see more formal ties with our program, which just got started 2 years ago. And like I said, I know my cohort members are really engaged in this work. And want to help grow that tribal public health workforce. The vast majority of us are Native people coming through institutions where some of us wanted to start out as doctors, or we didn't know what we were going to do, like the last person just shared. And so, knowing that there's a field of public health that includes, public health, but also healthcare delivery and even healthcare administration, because, that field can grow too, because those two systems work in parallel. And so, I just want to echo how much I agree with public health from, tribal college all the way up into the university setting. Just knowing that that's an option and knowing that we have Native people who are really engaged and wanting to grow this field. So appreciate the opportunity to share. Miigwech.
Thank you for sharing that, Cole, and good luck in your studies. So excited to see folks in their training. Any other thoughts, or are there any other questions that folks want to ask or comments you want to share about your efforts in supporting tribal public health workforce, key needs or priorities that we should be keeping our eyes on, key issues around this that you've perhaps experienced in your own work? I see some more folks in the chat about cultural competency training specifically for state and local public health entities that are working with tribes, and coordination, not competition, across different relationships to support tribal priorities. data sovereignty training. We are going to have a second webinar next week, and the series is on data and data capacity, exploring data sharing partnerships. So we hope you're able to join us for that as well next week. I noticed there were a number of comments around data and training specific to that. So we're hoping to continue the conversation around that piece in next week's webinar series. Also on Wednesday, and I'm continuing to see comments in the chat about establishing training programs, particularly for MPH. Somebody noted Dr. Warren's program at University of North Dakota and really supporting, again, that pathway to tribal public health careers. So I know I also went kind of quickly through the top section too, but we wanted to stop and ask if you had any questions about PHICCS specifically, the Public Health in Indian Country Capacity Scan, any questions about PHICCS 1 or our upcoming PHICCS. Some of you may have seen emails, notices about PHICCS 2, which will be launched soon in the next coming weeks. Okay. So we did just want to share, as I just mentioned, that the second Public Health in Indian Country Capacity Scan is coming up shortly in about 8 weeks or so, under 8 weeks. We expect to launch the second scan in late March. And again, this is a continuation of the work that was started with the first PHICCS and some of the information that we shared today, really to continue to understand the needs, priorities, and capacity for tribal public health infrastructure, specifically as described by tribal health and tribal public health organizations who are delivering these important services. This will allow tribes, organizations, partners, policymakers to better continue understanding and planning for the needs specific for tribal public health. We did want to note too that we are actively recruiting pilot sites to test the revised PHICCS 2 tool. If you are interested in participating, please email myself or Carrie Joseph, who's also here, and I will put our emails in the chat. Mine is also at the bottom of this. Please let us know if you are interested. We are more than happy to get your feedback on the tool or any of the processes to help make sure that PHICCS 2 meets the needs of tribes. Again, if you have any questions, email me, contact me, or Carrie. We did also just want to note too that NIHB's National Tribal Public Health Summit will be hosted this year on May 10th to 12th, 2022 in Anchorage, Alaska. We are currently accepting abstracts for this conference, which you can submit through this link here. We'll also post that in our follow-up information email. And you can submit an abstract to one of 5 topic areas, including COVID-19, vaccines, tribal public health infrastructure, climate change, health promotion, and mental and behavioral health. So if you have any questions about that, please don't hesitate to reach out to me. And we really hope to see you at TPHS 2022. With that, that closes our presentation for today. I'm happy to hang on for a little bit if there are other questions. This is my contact information. Again, feel free to email or call if you have any questions about PHICCS, about NIHB's work in tribal public health infrastructure, or anything else. As well, we did want to note that this is the first in a series of 3 webinars. The next webinar will be next week on Wednesday, January 26th from 3 to 4 p.m. Eastern. And that one will be focused on tribal public health data, data capacity. If you have any questions on how to register, just let me know. We'll send out a link as well. And then our third and final webinar in the series will be on February 9th at the same time, 3 to 4 p.m. Eastern, focused on tribal public health governance, public health authority, and the intersections of that with tribal sovereignty. So with that, thank you so much for joining us all today. We hope you all have a good and happy Wednesday, and we'll see you hopefully next week. Take care.